Good morning, and I wish to thank Professor Alio and the Aniridia Association for inviting me to this conference. I am going to try to review the spectrum of crystalline lens changes in Aniridia. So I'm going to concentrate on the phenotypical aspects, and then my friend and co-worker Juan Alvarez Toledo is going to introduce the surgical aspects of cataract aniridia. I'm sure you are all aware that aniridia is a disease with many different manifestations in the eye, from many different parts of the eye. But even if you look only at one particular part as the lens, there's also a wide variation of the possible degrees of manifestation. And that also creates a subtle dilemma or problem, because it looks very easy. Probably the cataract appears to be the easier problems to solve in aniridia, and that can be sometimes a trap, because sometimes it's very difficult to evaluate what is the actual impact of particular lens opacity in the complex problem of a particular patient. So we try to be didactic and try to summarize in a very simple concepts what are the possible changes in the lens in aniridia. We have changes in transparency, position, or size and shape. You see it's very, very frequent to have at least some opacities, almost up to 85%. But the actual cataract, and that's very difficult to define, so there's wide variation in what is the significant cataract. Then we have also problems in position, up to around at least 50% of the patient would have some degree of dislocation of the lens. Complete dislocation is not frequent, but possible. And there are sometimes cases with corneal lens adhesion that we will show also. And then we will have also some problems with size and shape, which range from congenital aphakia all the way to resorption of a cataract. And of course, one of the things is to characterize the morphology of these changes, but the mechanism is, I think, sometimes not so easy to decide whether, when we have a small lens, for example, whether this is due to a lack of development or it's just because there's a lack of corneal tension that prevents this development. This wide variation, I think, my wish would be one day that the geneticists are able to find what is the actual correlation between each of these morphologies and a particular change in genetics that might help us to decide when to treat or how to treat. So, from the transparency point of view, we can have, for instance, mostly clear lenses, which, if you look, there are always a little bit of opacities, like in this 10-year-old girl, there's a little point only in the posterior polar, or sometimes in this other case with early inferior opacities, which is normally associated with early inferior distension or early subluxation. And actually, this patient actually required a valve because she had also glaucoma, so there's also discussion whether there's a correlation between the displacement of the lens and glaucoma. This is another case which is apparently totally clear lens and 4-year-old, but of course that's the other problem, that we have low vision because of foveal hypoplasia, in this case with normal pressure. Of course there are some artifacts here because of the flashes. And this is one case which was catalogued of microspherophakia, but again, I'm not sure whether this is in a soft lens of a child. If the zonules are not pulling, the lens is going to look small. Then we have these anterior polar or subpolar cataracts. This is an older patient, 20-year-old male, with this anterior flat cataract plaque, isolated. This is another case of an older woman with a combination of this anterior polar and this quite characteristic coronary peripheral opacity, and again another young girl, 4-year-old, with this plaque, which is in the essentially interior part of the lens, which is characteristic ring of density in the periphery and relatively not so opaque in the center. And she had also choroidal coloboma. We can have this sometimes this more developed anterior polar pyramidal cataracts, and sometimes subcortical anterior cataract. That in this case, both eyes. One eye had this kind of older male, looked like polar, but actually was a subcortical nodule, which was in connection with the anterior pole of the fetal nucleus, and there were these arcuate lamellar extensions. The other eye, actually, these like two different plaques of cortex opacities in a plane just in front of the corticonuclear interface. That might be significant why these opacities develop just in this particular place. Then we have cases with more larger involvements, like these cases which have more posterior but also anterior subcapsular cataracts. This is a 25-year-old woman with Barraquer syndrome, and we have both posterior and anterior subcapsular and polar cataract since age 2. This is, I think, is an earlier, and then this is years later. The left eye had little progression, but with the right eye, which is here, we had this more diffuse cortical cataract with denser axial opacities. And here we have another case with only partial Aniridia, but 4-generation family history and central posterior subcapsular with peripheral branches. We can see here, and there was a, you can see, barely see here, maybe we could have less light here, you would see there's a mild dusty nuclear opacity, which is better to see with the black fundus than with the red reflex. Then I think we are now entering the cases where there's probably some significant impact on vision by the cataract, especially when you have these larger posterior subcapsular or subcortical cataracts. You see here there are two different cases. This is a 13-year-old boy with this kind of, let's say, coralliform or petaloid cataract, which is also quite typical, with these branches which converge in this central axial nodule in the subcortical area posterior, or this 34-year-old woman with much denser and it's clearly subcortical. It's not just the cortex, it's probably like what we call in surgery the epinucleus, which is involved. It looks like a lamellar cataract, but serious posterior. And also, I think it's important to know that in both cases the lower quadrants are more affected than the upper quadrants. That may be also connected with the fact that most of the dislocation also happens in the lower part. This is actually 3 different cases. These are 3 different cases. You look, the pattern looks quite similar. 17-year-old, 27 and 33, with this annular posterior lamellar subcapsular cataract, which respects relatively the visual axis. This is a little bit more extended here in the posterior part, and here is essentially equatorial with this and deep part of the lens. Finally, this 4th case, there's this combination of this anterior polar and this equatorial lamellar cataract, again denser in the lower hemisphere of the lens. Then we have nuclear cataracts. Sometimes you can have cataracts essentially limited to the fetal nucleus, as this is a, I think this is, yeah, this is a 12-year-old boy. He had also probably some psychomotor deficit, maybe a Gillespie, and she had this nuclear cataract seen since birth, but limited to the nuclei and no family history or kidney problems, although parents were consanguineous. And these are 2 cases different. Of course, there's this nuclear cataracts, or maybe these patients may develop the standard nuclear sclerosis but at the earlier ages. You can see this is a 41-year-old with already relatively luminescent nuclear cataract and also a little bit of subcortical opacities. And this is a younger woman of 28 with this opalescent nuclear cataract. And she had earlier seen only this posterior scapula dense plaque and later developed the nuclear opacity. She had also a limbal homograft, which was doing quite well. And if you look, both lenses are going upward already a little bit. Finally, we have the advanced and mature cataracts, which can be sometimes white, in this case, relatively soft. This is already an earlier phase with a 40-year-old with this opalescent nucleus, but the whole nucleus is already opaque. And this is a case with intermessage. Maybe there was some spontaneous breaking in the capsule because she had had this kind of situation for years, and suddenly she felt this fast decrease in visual acuity and presented with this mature cataract. And also the other eye, the left eye, had minimal opacities in this particular patient. Here it is an interesting case of cataract resorption in an older patient, 45-year-old, and cataract is advanced. It's a little bit irregular, but this phenomenon of cataract resorption has been found in some cases with Aniridia. And finally, we have this male with classical mature but very luminescent cataract and subluxation. So position, we can have probably partial. Already mentioned, it's at least in 50% of the occasion. It's usually upwards. Probably is secondary to ciliary body hyperplasia, and there's a question whether this actually facilitates glaucoma, which maybe this movement of the lens could create a progressive angle closure. And you have seen already that the cortical opacities tend to associate with this sector with greater soniolar defect. The complete dislocation may happen also. Lens falls into the vitreous chamber, and we will see one case at least of corneal lens adhesion that might be a form of anterior segment dysgenesis. Remember that some of these axis mutations have been also present in some cases with people with Peters anomaly. This is one single case, and you can see the evolution along like 30 years. When a 5-year-old child was almost transparent, already a small lens and displays upwards, called microspherophakia. This is at 21. You still have some cortical opacities in both eyes. At 27, suddenly there's this nuclear opalescent opacity, especially in the right eye, but also in the left. We're progressing actually faster in the left, and when we reach 35, this is the right eye, and the left eye has been already operated with a lens with artificial iris. This is a case of a 2-month-old boy with corneal lens adhesions in the periphery. There's this corneal opacity in the inferior nasal, so it's like in the colobomic area. And you can see there's also some remnants of the tunica vasculosa, and there was adhesion of the lens and the cornea in this area. So that's probably one side of the spectrum where we can see that this is relation between Aniridia and the other anterior segment dysgenesis. Size and shape, we have already mentioned. There are cases of agenesia or aphakia, congenital aphakia, sometimes associated with Peters anomaly. This microspherophakia, which again, there's this doubt whether this is actual lack of development of the lens or is due to the soniolar weakness, or maybe it's a combination of both factors. Sometimes it's described as lens glaucoma, but lens glaucoma may, in a soft eye, in a soft lens, may be due to the lack of soniolar support in one sector. And we have already shown this case with the spontaneous lens resorption, but it has been described in Japan 3 generations in a familiar form of this kind of evolution. This was a sporadic form in that particular patient. Sometimes you can have this so-called anterior lenticonus, and again, as you can see, the anterior lens is much more curved than the posterior, and had a little bit of bump here, but that's not really clear what is the cause of this change of curvature. Is something genuine from the development of the lens, or maybe is secondary to the problems at the level of the zonules. It has been shown from studies with Herman and echo that the pattern is different from the traumatic dislocation changes in the shape, and that, as you can see, may appear in the absence of the cataract. So, just to summarize, and then we will have the opportunity of discussing with Juan the surgical aspects, but lens opacities, of course, are very frequent. There are various types, and it's a different evolution. Is this something genetic, or maybe there are some environmental factors? Only part of them become really significant cataracts, and usually by slow progression. Sometimes can be fast, as we have seen. So, from point of view of the clinician, our biggest dilemma is to decide, in the cases of congenital lens opacities with a degree which looks significant, or a child with this kind of situation, how to evaluate the actual impact and the cause of amblyopia. But of course, this is sometimes very difficult because it depends on the macula, the optic nerve, and other factors. And again, also, especially in children, I think we have to be very aware that these eyes are especially reactive, right? Something related to the genetic problem. And I have personally lived some cases with this reaction with the anterior segment fibrosis syndrome after cataract surgery. So I think we have been becoming more and more conservative before deciding to operate on these cases. Regarding dislocation, of course, there is some dislocation. It's slowly progressive, and of course, it's again difficult to decide when is the moment to do something about it from the surgical point of view. But also, it's important to remember that it has been associated with a greater tendency to glaucoma. And of course, this is important to decide, because even if the dislocation is only very mild, it may progress. So in the moment of deciding which kind of lens are we going to put in a young person, we have to consider that this person is going to live for many decades, and maybe we should think about fixation of the lens, which is going to be for all their life, not just sometimes not just in the back. And I think that's all for the moment. Thank you very much for your attention.